Mr. Chairman, ladies and gentlemen, I am so pleased to be in St. Petersburg this afternoon to speak to you about genetic testing in the clinic. And by genetic testing, we mean inherited genetic testing. Can you hear me at the back? Can you hear what I say at the back? Yeah. When I received the invitation to come here, I have to admit that I really did not understand what white knights meant. But having been here yesterday evening and had it explained to me, I now understand what white knights mean in St. Petersburg. So what I would like to do this afternoon is start by telling you a little bit, one slide, about my professional background. And then to go on and talk about inherited genetic testing in the clinic. And initially, in the first half of the talk, to talk about testing for the breast and ovarian cancer genes called BRCA1 and BRCA2. We have had extensive clinical experience with testing for these genes, and I want to tell you about some of the messages that we have learnt are important to pass on to patients, to both cancer patients and their relatives, about genetic testing. And then I want to move on to a new development which we have recently introduced in London, where rather than just offering testing for the two genes, BRCA1 and 2, we are now in a position to offer testing for a panel of inherited genes, all on the same sample. This is a major innovation from a technical point of view. I don't want to spend much time on that. What I want to do is look at the clinical messages to get over to patients when we're talking to them about this new panel testing as a concept. And then I'd just like to finish by telling you briefly about our early experience in introducing panel testing in London. And then lastly, just tell you about an interesting and complicated family in whom we used the panel test. And the chairman has suggested that I limit my talk to around 20 minutes in the hope that we can then have time for some questions and answers. So let me start with my professional background. I trained as a consultant in medical oncology in Edinburgh. As a young man, many years ago now, I did some laboratory research into the genetics of breast cancer. That was in 1985, when many people believed that there was no such thing as a breast cancer gene. And I remember a senior surgeon in Edinburgh, when I was young, telling me that I was wasting my time looking at genetic breast cancer. So that shows that even in Edinburgh, sometimes the surgeons get it wrong. Then I came down to set up the NHS, the public sector cancer genetics service based in Cambridge. Then I moved to London to set up the NHS cancer genetics service in London. And then I left the NHS, the public sector, in 2006 to establish private practice in London. And I became the clinical advisor to Myriad Genetics in 2013. And I'll tell you a little bit about their testing as we go along. This cartoon illustrates the situation. The green circle patients with breast and ovarian cancer. The purple circle represents their female relatives. All of these relatives are at slightly increased risk of developing breast or ovarian cancer themselves. But within that group, there is a group at significantly increased risk. And more importantly, within that group, there's a small group who are at high risk of developing breast or ovarian cancer themselves because they have a very strong family history. And that is the group that initially we're going to concentrate on. So what we're talking about is providing a clinical service, the clinical messages to those with a family history of breast and ovarian cancer. This pedigree illustrates the sort of patient we see in the clinic. A circle is a woman, the right-hand side shaded shows breast cancer, the lower circle shaded shows ovarian. This lady has a strong family history of breast cancer, her aunt had ovarian cancer, and her cousin has breast cancer at a young age. What are the important messages to get over to this lady? Well, the first important message is that even if there is a faulty gene in the family, her mother has one good copy and one faulty copy of the gene. And her mother only passes one copy to her. So there's a 50% chance that her mother passes her the good copy. And that means it is impossible for this lady, who's well, to be at more than 50% chance of developing breast cancer herself. And that's a really, really important clinical message. However strong the family history, however many young women in your family have died of breast cancer, in that situation, that lady is at 50% chance of inheriting the good copy. And that's a clinical message that is often missed. We then to go on to the concept of describing the genetic testing process. And I accept that this is rather simplistic, but it's yet very useful just so everyone understands what we do. So a gene, the BRCA gene, BRCA1, is made up of the letters C, G, A, and T. In the BRCA1 gene, there are 100,000 letters arranged in a sequence, and a faulty gene is caused by a change of a single letter. So it's a subtle spelling mistake, and it can be anywhere along the whole sequence of the gene. So that means in clinical practice traditionally, genetic testing is a two-step process. First step, we have to identify a fault in the family, and we do that by taking a blood sample for someone in the family who has had either breast cancer or ovarian cancer, work our way along the whole sequence of their BRCA1 and 2 genes, and only if we manage to find a fault in that lady can we go on in the second step to offer testing to other people in the family. So once you've identified the fault in the mother, then you can offer testing to the daughter, and that will tell you definitely if the daughter has inherited the good copy or the faulty copy. So traditionally, genetic testing is a two-step process. When you do the business of working your way along the whole sequence of the gene, there are three possible results we get from the laboratory. One possible result, they've looked at the whole sequence of BRCA1 and 2 and they're completely normal. Or they've looked at BRCA1 and 2, they've found a true fault, and that patient is at high risk of both breast and ovarian cancer. But more importantly, and this is a point that is often not well realized, sometimes the laboratory identify an alteration in the letters that they're not sure what it means, and they report that as a variant of unknown significance. So they're not sure if it's part of normal variation between normal humans and of no importance whatsoever, or if it's a true mutation, which is very important. Because if a well lady carries a true mutation in BRCA1, her risk of developing breast cancer at a young age is high. It's around 50%, whereas the normal population risk is around 1 to 2% of developing breast cancer below the age of 50. But almost more importantly, and we'll come on to this in a few minutes, her risk of developing ovarian cancer in her lifetime is very high. A BRCA1 mutation carrier is around 40% chance of developing ovarian cancer in their lifetime, compared to the normal population, which is around 1%. We know that screening for ovarian cancer in high-risk women does not work. Therefore, in women who truly have a high risk of ovarian cancer, we will probably discuss with them about having their ovaries removed as an insurance policy from around the age of 40 or older. And in many women, that will save their lives from ovarian cancer. So this whole issue of identifying a variant, a change in the letters, and you're not sure whether it's important or not, is a crucial issue for both doctors and patients. It causes massive increased anxiety because of the uncertainty. As I mentioned, some of these will have a true mutation, and they are the ones who should think about having their ovaries out in a prophylactic oophorectomy. The current frequency in the public health system in the UK of these variants is well over 10%. 1 in 10 women offered testing in the NHS in the UK will end up with a result which we're not clear about. So this information, as we'll see, is important. It's important for patients. The frequency of variants in myriad genetics is less than 1%. And the reason is that they have the largest database in the world. So Myriad Genetics have done over 1,500,000 BRCA1 and 2 tests. So their frequency is low, but it still happens. And I explain this to everyone who's thinking about testing, because if you don't explain it and it comes back with one of these variants, it's very hard to explain it afterwards. But of course, the traditional method has now started to change, because technically we can offer testing to anyone. We can take a blood sample, we can work our way through the whole sequence of BRCA1 and 2. And increasingly in the UK, and over half the time now in the States, they are actually testing unaffected people initially. It's important that we have a full discussion of the available management options, in particular this concern about the ovarian cancer risk. It's a careful process which tends to be slow. Currently within the NHS we have strict criteria which for inclusion of testing, often the waiting list is long, whereas in the private sector there's no waiting list. We in general can offer testing to anyone who wishes it as long as they're happy they understand it, and as I said, all tests go to Myriad Genetics. Currently in the UK, the big insurance company, which is called Bupa, the medical insurance company, has changed its policy over the last year, and Bupa will now pay for testing for patients who fulfill these criteria. So if you're a lady with either breast or ovarian cancer and you have what they call a strong family history, then they will cover testing. But in some ways, we have overemphasized the importance of family history. Consider this lady. She developed triple-negative breast cancer age 33. She has no family history of breast or ovarian cancer. She's 2 children, aged 3 and 18 months old. This lady has around a 6 to 8% chance of carrying a mutation in BRCA1 or BRCA2. If this lady carries a mutation in BRCA1, she should think about having her ovaries removed after the age of 40. If she does not carry a mutation in BRCA1 or 2, she's not at increased risk of ovarian cancer. So it's a very black-white situation. So I think it's important that ladies in this clinical position are offered information about testing. I'm not saying everyone should be tested. I'm saying they should be offered information about testing. And ironically, the reason is because of the breast and ovarian cancer being so interlinked in BRCA1 and 2 carriers, actually her greatest danger is from ovarian cancer. If she carries a mutation, this lady is at 40% of developing ovarian cancer in her lifetime. And almost all these ladies will consider having a prophylactic oophorectomy in order to prevent themselves getting ovarian cancer. So in summary, I've put up on this slide the various important steps that we've learnt from long experience of BRCA1 and 2 testing. Brief description of the process as I've told you, talk about the variants of unknown significance, talk about the test results, possible implications. I give everyone the result by phone, so as soon as I have the result I speak to them on the phone, because if it comes back normal it's a very short conversation usually. And in most families a mutation is not identified. So this is a typical family like I showed you at the beginning. We've tested this lady's sister. There's a strong family history, but BRCA1 and 2 come back negative. What we say is it's probable that this is genetic because of the strong family history. It's probably not BRCA1 or 2 because we've tested them. It's probably a gene that at present we cannot test. And that is what drove the introduction of this new panel testing. So we now have a panel test that I'll tell you a little bit about, where we can look at 25 different cancer genes, and I'll show you them in a second in the clinic. Again, we talk about the fact that the process of testing, we mention that these genes are involved in different types of cancer, and I'll show you that. And this test takes longer to do because, of course, we have to sequence all 25 genes. So it takes 4 to 5 weeks. Offers 25 different genes, including the whole of BRCA1 and 2, but a total of 12 breast and ovarian cancer genes. But genes involved in other cancers like inherited bowel cancer, cancer of the womb. And this panel here just describes the test. The name of the genes are down the left-hand side, and the various cancers involved along the top. So you can see there's 8 common cancers. Several of these genes are involved in a number of different cancers. Several cancers have a number of genes involved. So it's very much a much broader panel that we can now offer to patients if they wish. So let me just go on now to tell you about our early experience in London. 3 different centres in which I work. We've done 240 tests in the first year, and we've had 212 results so far, so I'm going to report to you on that. In these 212 families, we've identified mutations in 39 families. 20 of these families, it was in BRCA1 and 2, and a further 19, it was in other important inherited genes that are not BRCA1 and 2. So by introducing this test, we've doubled the number of families in which we identify important mutations when comparing the panel test to BRCA1 and 2. Say mutations identified in 19.4 families, but of course as we're looking at more genes, the number of variant of unknown significance has increased. But more importantly, even with the 25 gene test, most of the families we see, the result still comes back as normal. So let me just end now by briefly telling you about a relatively complicated family which I hope may be of interest. So I saw these 2 ladies, their sisters, in the clinic. This lady had had a PNET, primitive neuroectodermal tumour, age 12. She'd had a T-cell lymphoblastic leukemia, age 17, and she'd had colon cancer, age 19. Her sister had had colon cancer, age 22. They came to the clinic with their mum. Their mum and their dad were first cousins. And there's a strong family history of both bowel cancer and uterine cancer on both sides of the family. On both sides because, of course, the mother and father are first cousins. Very complicated clinical family. So we offered these 2 girls the MyRisk test, and the result came back that they had a true fault in the BRCA1 gene. Now there's another gene involved in inherited bowel and womb cancer called PMS2. What stands for doesn't matter, it's called PMS2. Normally if you have one fault in PMS2, you're at high risk of developing both bowel cancer and uterine cancer. Both these girls had two faults. So both of their PMS2 genes were faulty. That has been reported in the literature. It's very rare, but we've never seen it before in a family who also have a BRCA1 mutation. So complicated clinical finding. We now had to go on and look after the well people in the family. So we offered testing to the mother, looking at her BRCA1 and PMS2. Her BRCA1 was normal, and she had one fault in PMS2. The two ladies we saw had three brothers, aged 25, 20, and 16. We tested each of them. The two oldest brothers, aged 25 and 20, had a faulty BRCA1 gene and two faults in their bowel and womb cancer gene. The youngest brother had a normal BRCA1 and a fault in one of his genes. What were we going to do with a complicated family like this? And this is where the Myriad professional support system comes into play, that they will give advice to the clinicians on what they suggest should be done. And we'll just look at that in a second. So the advice which came was that the mother should have a baseline colonoscopy immediately. Remember, she's got a normal BRCA1 and a single PMS2 fault. The two brothers, the two elder brothers, who have got both PMS2 faults and a BRCA1 fault, that they should have immediate colonoscopy. And if it was normal, they should have a colonoscopy every year, because these boys are at very high risk of developing bowel cancer. Because of the BRCA1 mutation, they should think about regular self-chest examination and think about prostate screening from around the age of 40. The youngest boy was only 16. Remember, he's only got one PMS2 fault. Suggestion was he had baseline colonoscopy age 25. His risk is still increased of developing bowel cancer, but it's not nearly as high as his two brothers, and the suggestion was that he would have colonoscopy every 2 years. Let's just go back. The two girls that came initially to see us, one with a PNET age 12, acute lymphoblastic leukemia age 17, colorectal cancer age 19, our sister with colorectal cancer age 22. They have two faulty PMS2 genes and a faulty BRCA1 gene. The suggestion was that they should have annual MRI breast screening, American guidelines, so from around the age of 30, and they should consider having their ovaries removed from around the age of 35. That girl who came age 19, who'd had 3 separate primary cancers already, are we really going to suggest to that girl that she should consider having her ovaries out at 35 in another 16 years' time? So we decided not to suggest that. We decided the simplest way was to leave the care of that patient in the clinical oncologist who was looking after her. So at the end of the day, the message from this complicated, difficult family is, however good the professional support system that one has available, one has to take the advice and use it in the appropriate clinical context. So, ladies and gentlemen, we've looked briefly at the concept of BRCA1 and 2 testing in the clinic based on relatively extensive experience over the last 10-15 years of offering testing. We've highlighted the different messages that I believe are important to give to patients, cancer patients and their families about testing. The most important clinical message of the whole lot is this strong link between breast and ovarian cancer and BRCA1 and 2 carriers. And therefore I personally believe that all those who've developed breast cancer at a young age, irrespective of their family history, should be offered information about BRCA1 and 2 testing. Because if these ladies have a true mutation, then they're at high risk of developing ovarian cancer, which may well kill them, and they will normally consider having their ovaries out from the age of 40. We've briefly gone on to talk about the panel test, which is now available. It's not for everyone, and I don't suggest it is, but it's certainly a welcome introduction. Patients have welcomed it in London. They seem to be more reassured if the MyRisk 25 gene test comes back normal. But again, at the end of the day, the most important clinical message remains that even in these high-risk families, even with the 25 gene test, we still often don't find a fault. And therefore the message there is that although the 25 gene panel test is a big step forward, we're nowhere near understanding all the important genes involved in inherited cancer. Thank you very much for your attention.
Thank you very much, Professor Mackay. The paper is open for discussion. Okay, questions? Okay, I will start with myself. Okay, I have. Да. Пожалуйста, пожалуйста, да.
So I can only talk to you about testing in the UK.
Yeah.
The complete myriad sequencing of BRCA1 and BRCA2 in the UK cost £1,455. The MyRisk test, the 25 gene test in the UK, cost £2,238. But understand the pricing structure is very different in various different countries across the world.
Есть еще вопросы? Another question? Okay. If I understand correctly, you recommend prophylactic oophorectomy after age 40? Then how females accept this proposal to make this operation?
So I think that the most important factor in this is the concept of what is the risk of ovarian cancer. That if you're telling a lady that she's at high risk of developing ovarian cancer, that causes massive concern. And the reason is that in general the public are very, very scared of ovarian cancer. They know it is the silent killer. They know that it's not easy to screen for it. And they know that if they are at high risk, they may well die from ovarian cancer. So when you balance that against the risks of oophorectomy, then it becomes very important. I think it's really important, and I'm sure the meaning of your question is that it's really important that we do not underestimate the risks of prophylactic oophorectomy. And I certainly wouldn't advocate it in patients who aren't at high risk of ovarian cancer. But those who are truly at high risk of ovarian cancer, the vast majority will decide to have a prophylactic oophorectomy. Around the age of 40 is just a guide. It depends on the clinical context, whether they've finished having children, all that. But what we would suggest is not before the age of 40.
Okay, and my last question may be about males who have positive in regard of BRCA1. How often actually they have some cancers? I don't know. For example, you said colon, chest, prostate. Is it often?
Yes, thanks. I should have mentioned this actually. So in the situation we're talking about with that unaffected girl, her mum has one good copy and one faulty copy. That girl's at 50% chance of getting the faulty one. It's exactly the same for the boys. So if that lady had a son, he's at 50% chance of inheriting the faulty copy. If a man inherits a faulty copy of BRCA1, his prostate cancer risk, young prostate cancer, goes up about 3 to 4 times. A BRCA2 male carrier, his risk of young prostate cancer goes up about 8 to 10 times. So it's a significant increase, particularly in BRCA2 male carriers. 8 to 10%. Yeah. And that's of young prostate cancer below the age of about 50. We don't have a proper standardised prostate screening system in UK. So these people tend to go on sort of ad hoc screening system with PSA, which isn't very satisfactory, but to be truthful, but anyway, it's the best we've got. But what's important is if a male carries the fault, and he then has daughters, it's the same story. He has one good copy, one faulty, 50% chance that daughter getting the faulty one.
Thank you very much. Have you any approved state standards for care and treatment of BRCA carriers? Approved state from government. Approved from government. Permission, yes.
So this hasn't been properly looked at, in truth, by NICE, which is our government body. They have looked at the whole implications of inherited breast cancer, and there are clear guidelines from NICE about who should be offered testing and what one should say to carriers about having regular MRI or whatever. But they haven't yet moved on to properly consider the ovarian cancer risk. But having said that, I think it's widely accepted in many guidelines internationally that ovarian cancer screening doesn't work in the high-risk group. I must be clear, it's only the high-risk group. There's a big study ongoing in the population, and ovarian cancer screening may work in the population. It's in the high-risk group, which we did a study in the UK called UK FOX, FOCS, and it was clear that using CA125 and ovarian ultrasound, we weren't picking up the cancers quickly enough to allow us to always treat them successfully, which is why we suggest to people at truly high risk that they think about prophylactic oophorectomy.